Continuing our series of videos on updates to the state protocols for 2023. Once again, if you do not have these as your active approved protocols, then don't consider this to be a medical control order or anything like that. You have to follow the orders that are laid out by your service medical director and ratified by the Board of EMS for protocols. So if your service has adopted these, great. Welcome to the party. And if they haven't, then maybe consider it, but maybe consider this just educational. Otherwise, this is not necessarily your protocols, unless they are your protocols. That said, let's talk about CHF. The indications for this particular protocol are going to be somebody that's in respiratory distress with either appearance of volume overload because, they're frankly edematous all over and have 4+ pitting edema up to the level of their rib cage or something like that. This could be somebody that has suspected flash pulmonary edema where they're very hypertensive and all of a sudden got really short of breath and is hypoxic and has RAWs all the way through their lung exam. Somebody that has a history of congestive heart failure who's in respiratory distress with symptoms that feel like they're CHF, or somebody who has a history suggestive of volume overload with respiratory distress, i.e. I've missed dialysis 4 days in a row because I was so short of breath I couldn't get out of bed. Those folks are going to be included with this. Folks that we are not going to include with this, one is a systolic blood pressure less than 100. We should consider cardiogenic shock or septic shock in these folks. Or that said, anybody with a fever, infectious symptoms, because it's most likely not in that case, CHF, although it can be. And then somebody that's respiratory distress that seems more like a COPD or asthma exacerbation based on clinical assessment or history, we wouldn't necessarily follow this protocol. And that can be difficult to tell. A lot of folks have COPD and CHF. And what do you do about that? Well, the good thing is that most of these treatments, if you give one and it is not the right condition, it generally is not going to hurt the other. It just might not make them a bunch better. So pick whichever one seems the most likely and go ahead and treat that way. But just kind of be aware that some of these overlap a little bit. So our general treatment guidelines, we're going to do a good assessment. We're going to obtain a 12-lead EKG. Don't forget that one of the primary presenting complaints, one of the most common presenting complaints for a STEMI is shortness of breath. And that can certainly happen in somebody that has CHF. So get that EKG early. We're going to give oxygen to keep their oxygen saturation between 94 and 99%, not going over 99% because that's too much and you don't need too much. It doesn't help even if they say I'm short of breath. If their SAT is 99%, they don't need more oxygen. They probably just need to ventilate better with some of the stuff that we'll look at here. You can use end-tidal CO2, which is certainly a helpful thing, but a little more than what I want to get into with this particular video. Just consider using it in these folks with respiratory distress. And just remember that just because you're not swollen up in your arms and legs doesn't mean that you don't have an excess of lung water or pulmonary edema. And if they have a history of CHF and this feels like their CHF, there's a good chance this is their CHF, and you can go ahead and treat as we would do here. Now, you'll notice a couple of things. One, just on the format of this particular protocol, we intentionally took out the green, yellow, red, stoplight type things that define provider levels. The reason for that is, again, intentional. It's not that we forgot to do it. It's that information is stored in a different document under the scope of practice section of the website, which you should look at, be familiar with, and keep track of. The reason that we didn't put it in here specifically is that we didn't want to have to go back and revisit every single line in a protocol when all we need to do is change that other document to change the scope of practice, because that's what happened with the last set of protocols, is that they didn't get updated, or there's room for error when you didn't update quite everybody. So in order to minimize the chance of any of that happening, there's now one scope of practice document and one set of protocols that we are bit by bit transitioning into just being the protocols themselves. So you are responsible for knowing your scope of practice. Let's just say that. Now, let's talk back at CHF again as we get into treatments and what you can do about this. The treatment paradigm always used to be, whenever somebody said CHF, somebody would say, give them Lasix and give them morphine. Give them a diuretic and then give them morphine, because morphine makes people who are short of breath, like in hospice, feel better. And that's true, but giving somebody a bunch of morphine when they're in respiratory distress yes, will make them feel better, but it's also associated with worse outcomes and a higher risk of death. So that seems not quite such a good idea anymore. The Lasix itself doesn't really have an evidence base for acute treatment of CHF exacerbations. Certainly in the short term, i.e. the amount of time that we'll have them in EMS, Lasix furosemide is going to take somewhere between 45 minutes, an hour to even really kind of start making the person pee. And the problem may not be that the person is volume overloaded per se. It might just be that volume is in the wrong space, i.e. in their lungs and not in their bloodstream. So diuresing them may not be the best idea. So we've taken that out. What is the treatment paradigm? What are we going to do for CHF patients? We are going to administer nitroglycerin to reduce preload and afterload, decrease essentially the work of the heart because it is in failure and it's not able to work as well. We're going to do that, and we're going to provide non-invasive positive pressure ventilation, i.e. CPAP or BiPAP, as needed. So the nitroglycerin, let's talk that real quick. We are going to obtain a blood pressure, and we're going to dose the nitroglycerin based on the blood pressure, not with the idea that we are going to treat the blood pressure per se, but that lets us know how aggressive we can be with giving somebody nitroglycerin. So if their systolic blood pressure is greater than 160, and take this a couple of times, make sure it's a good reading, we're going to give 0.8 milligrams of nitroglycerin sublingual every 5 minutes up to 3 doses. If their blood pressure during that treatment either goes down below 160, or if it starts less than 160, we'll give 1 tab at a time. And again, we're going to do that for 3 doses. How long should you continue doing it? Well, until they become either a systolic of 100 and let's say 110, really. I'll make that change in the next update here. 100 to 110 on their systolic, or the patient says that they feel better. And that's when you'll stop giving the nitroglycerin. If you've started by giving that bolus nitroglycerin via the mouth at 400 micrograms at a time, what you can then do is start them on a nitroglycerin infusion. I think this is a ALS level. This is paramedic. Just FYI. You will start the dose at about 50 micrograms per minute for CHF or pulmonary edema. This isn't the dinky little 5 or 10 that folks may see in the hospital for quote-unquote chest pain that's better with nitroglycerin. This is actual doses. And then we're not just going to leave it at 50 mics per minute. We're going to increase that dose by 25 or 50 mics per minute every 5 minutes until the patient says, yes, I feel better, I'm breathing more comfortably, or they get their blood pressure to 110 systolic. And of course, you're going to check that blood pressure fairly frequently. There's always the caveat that if the patient's taken ED drugs like sildenafil in the last 48 hours, that maybe you should not give them nitroglycerin. If the patient's blood pressure is still 180 systolic, I'm probably going to go ahead and give that person nitroglycerin, honestly, but consider making a medical control call about that to discuss it with them. And if the patient's on an infusion like milrinone or epoprostenol or something like that, then I would probably avoid giving them nitroglycerin. Just in general, that's so it's a little more complicated than the average bird that we're talking about here. So we've given nitroglycerin, and the nitroglycerin will essentially decrease the work that the heart has to do to pump blood around. It'll decrease preload at lower doses. Once you get up to around 250, 300 micrograms per minute, you start to actually get into the area where you decrease afterload on the heart by causing arterial dilation, which is really what we want, which is why we give these high doses. The other thing we're going to do after we give the nitroglycerin as medication is consider CPAP or BiPAP, non-invasive positive pressure ventilation, on these folks. And the person doesn't have to be hypoxic in order to benefit from CPAP or BiPAP. That little bit of pressure, that PEEP, will help folks who are in respiratory distress. And this is a good thing for the guy who is satting okay. He's satting 96%. He doesn't necessarily have to go on the BiPAP like we think of, where it's our last-ditch effort before we intubate him. This will make the person breathe more comfortably, help redistribute the lung water, and overall will make the patient better. So even if their SAT is greater than 94, they could still go on non-invasive positive pressure ventilation. And by the way, it is not a strict contraindication that you use the person has to be GCS 15 in order to use CPAP or BiPAP. In fact, many of these patients who are hypercarbic, if you put CPAP or BiPAP on them for a period of time, in 5 or 10 minutes as they start to clear out some of that CO2 and they start to get a little blood and oxygen back to their brain, that mental status improves a lot. But again, the thing is, you have to be really careful when you do that. You have to be constantly watching them. You have to be sitting there ready to rip that mask off their face if they begin to vomit or showing signs of aspiration or anything like that, if the patient is somewhat altered. But if they will accept it, you can still do it. You just have to be very cautious with it. Now, if you are going to bag this person, essentially, if they're in extremis or peri-arrest, they don't tolerate BiPAP, you may need to provide some BVM ventilation. I recommend always using a two-hand technique because that's really the only way to do it. Use a PEEP valve on these folks and set it at least 5, maybe crank it up to 7.5 or 10. For that, you're going to have a good seal, which is where the second provider comes in to do that good two-handed mask squeeze. And then consider using the use of a nasal cannula flowing at 15 liters per minute underneath the BVM mask, because that will actually provide you the PEEP that you want. I've got a whole other video that details that. Check out the one that's on great airway things to do, even if you don't have a vent and that kind of stuff. It's in there. Now, there are some folks that have non-cardiogenic pulmonary edema, i.e. they were exposed to chlorine gas or something like that, or they were down for a long time with an opiate overdose. Now they are awake, but they have pulmonary edema. That's a thing that happens. It's not necessarily the Narcan that does it. It's the fact they didn't breathe for a while. But anyway, that's not because their heart is failing. That's because their lungs are having trouble. For these folks, you can consider using albuterol or protropium if they seem to have COPD-type symptoms like wheezing. You can still put them on BiPAP as above. These folks just probably won't benefit from nitroglycerin unless they're markedly hypertensive as well. You know, again, systolic of 190 with RALs all through their lung exam. That person would probably benefit from maybe some nitroglycerin, but definitely from non-invasive positive pressure ventilation. So don't be afraid to get that out, but you don't necessarily have to give the nitroglycerin to these folks if it is presumed to be something else, primarily lung in etiology. That said, that's what we've got for this one. Stay safe out there, and we will catch you on the next one.